Any health-related information on the following show provides general information only. Content presented on any show by any host or guest should not be substituted for a doctor's advice. Always consult your physician before beginning any new diet, exercise, or treatment program.
Hello, everyone. This is Joni Aldrich, and welcome to CancerSOS. We're so thankful to have you with us wherever you are in the world today as we talk about the important topic of breast cancer and breast care. You know, I was talking this morning with a dear friend of mine, Miss Kathleen Fitzgerald, who is we're working together on a new book of survivors. Of course, Kathy is the talent on this one, and Kathleen is a world-renowned author and photographer. And we had the pleasure of being in Nashville, Tennessee this year to film many cancer survivors for a new book on women with cancer called Survivor. We were talking this morning, we're working on the introduction to the book, and I was telling Kathy, you know, it's amazing in the world of cancer. We talk about so many advancements, and there are many advancements every single day, and thank goodness for them, because now we have 14 to 16 million cancer survivors in the world, in the U.S., really, just in the U.S., and many more around the world. And that is thankfully due to much better research, much better diagnosis techniques, but we still have a long way to go. There are still women that don't make it with breast cancer. There are still men that don't make it with many different types of cancer, including men can get breast cancer too. So, you know, what we're talking about today is work in research to help in many areas of cancer, and it's so important that we continue to increase the number of cancer survivors. And in order to do that, we need researchers like the ones that we have on the show today. So I want to tell you a little bit about Dr. Gail Lebovic, and she is an MA, MD, FACS, and she has committed her career to developing new techniques in the diagnosis, treatment, and post-operative care of breast cancer patients. In addition to her clinical work, Dr. Lebovic has been recognized as a creative inventor and entrepreneur. She is well known as the inventor of the MammaPad to provide a softer mammogram, and she has served as founder of 7 other medical device companies. Dr. Lebovic is one of a handful of women holding numerous patents, and she is credited around the world as one of the original pioneers in the field of oncoplastic surgery. She has received several distinguished awards, including the Spirit of Achievement Award from the American Cancer Society and the Pathfinder Award from the American Society of Breast Disease in 2014. She is currently Chief Medical Officer at Focal Therapeutics, Incorporated. In addition to her innovative clinical work and medical device development, Dr. Lebovic remains actively involved as a philanthropist, global educator in the field of breast surgery, and a passionate voice as a patient advocate. She has served as president of the American Society of Breast Disease and chair of the World Congress on Breast Health Care this year. So welcome, Dr. Lebovic.
Thank you, Joni. Thank you very much for having us.
Wow, I'm really, really looking forward to hearing more. And definitely, we want to talk about oncoplastic surgery as well and make sure that everyone understands that. So, thank you so much for being here. It's very exciting. And also, Dr. Ryan Fott, and he is a radiation oncologist at the Mitchell Memorial Cancer Center, which is part of Owensboro Health in Owensboro, Kentucky. He's been in practice since 2009, and he completed residency training at the Medical College of Wisconsin in Milwaukee and is board certified in radiology. Welcome, Dr. Fott.
Thank you for having me.
Oh, this is so amazing. So, I'm going to go a little off schedule already, and I hope you'll give me that opportunity because I really want to talk about what is oncoplastic surgery.
I think that's a great place to start. Oncoplastic surgery is really the combination of cancer removal surgery and plastic and reconstructive surgery. So if I can just expand on that a little bit, what it means is as cancer surgeons, we're trained to remove all of the cancer and make sure that the surrounding areas don't have any remnants of cancer. And we do the best job we can at that. But oftentimes it's at the expense of surrounding tissue. And in the breast, that's particularly important because it means we might take out more skin than necessary. And before, historically, for breast cancer, we removed the whole breast. So oncoplastic surgery is really a way of thinking in terms of preserving as much skin as possible, keeping as much of the natural breast tissue as possible, and if the entire breast needs to be removed, then we start the reconstruction at the same time.
Wow. So it's really comprehensive in all areas of what you're doing. And it's amazing because, I was looking at this one question that I have here for you. Your life's work has been focused on breast cancer care, not just improving the care itself, but doing it in a way that takes into account the women's experiences and the overall quality of life. And it sounds like to me what you're talking about with the oncoplastic surgery is exactly that thing, is being able to do more at one time.
That's exactly right. And looking back on kind of my education and training and my career, it really happened somewhat by accident. It was my exposure as a medical student to seeing women who were suffering from breast cancer go through the experience of mastectomy, which was really the only option at the time. And I think it hit me so hard to watch them go through that experience. And I was a young woman in my 20s, and I thought, wow, there really has to be a better way to do this. And that kind of led me down the path of surgery and ultimately trying to figure out ways to save more of the skin. And other researchers were working on saving the entire breast or breast conservation. And so it was a very exciting time, I think, in the last 25 to 30 years to be in the field of breast care because it is much better now.
And what you're talking about is an overall better quality of life for the patients than ever before, really.
Yeah, I think as a surgeon and as a physician, you always have to put yourself in the patient's position and imagine how you would want to be treated, and then really strive to make those improvements so that whether it's you or a family member or a friend or any of your patients, you're really trying to get them the best outcome for their life because a diagnosis of cancer, as we know, really changes your life. Forever.
Absolutely. Absolutely. So what are the parameters that you go about deciding who are good candidates for oncoplastic surgery?
A great question. I think Nowadays with screening mammography, we are doing much better at diagnosing breast cancer early. So that has allowed us to be much more creative on the surgical side. And the majority of women, at least 60 or 65% of women, are now good candidates for these types of surgical procedures.
Wow. So, so this is pretty much is this becoming a standard of care then? That in many areas of the U.S. this is available. Who performs the oncoplastic surgery?
Well, I'll tell you, when I first started doing this, probably for the first 15 to 20 years, it was just me in the United States doing this, and it was pretty lonely out there.
I'll bet.
Yeah,
sad
but over
for the
last
patients.
But over the last 10 years, that's why I've spent quite a bit of time and energy and effort trying to teach other surgeons to do this. And now there's a very large movement of breast surgeons and general surgeons to learn these types of procedures. They're very excited about it, and it's a bit easier for women to find surgeons who are doing oncoplastic surgery.
So, so basically, if a woman is interested in it, she should ask her doctor and see where it might be performed wherever they are locally.
Yeah, that's a good way to start. And also, I think the American Society of Breast Surgeons and the American Society of Breast Disease, both of those are good resources online to look for people who specialize in oncoplastic surgery. And I'm just really excited that the trend is it's growing. So in the future, we hope to actually integrate this into the surgical training programs so that at the universities, the surgeons that are coming out will all have these skills. That's where we really hope to go with it.
Well, I hope you get to that point because it sounds absolutely amazing, and it sounds like you've come a long way. I think I've noticed in the breast cancer community that sometimes it does take longer than normal to get some of these new ways of doing things out there. So it sounds like you're really making progress, and there is hope in the future.
Yeah, I would agree with you. I think change in medicine is slow, but I think it's slow for a reason. I think we all want to see change come and improvements in care, but we want to do that very carefully and cautiously, particularly in surgery, because you don't want to sacrifice, not doing a good cancer operation just to have a good cosmetic outcome. And that's why there is a very important balance between the two, and why it's called oncoplastic surgery. In other words, the cancer portion is more important to some extent than the cosmetic.
Of course, absolutely. That always has to be the primary focus, of course. Mm-hmm. Do you find, just a quick question, Dr. Lebovic, I know that there are women that decide not to have the plastic surgery after breast cancer treatment. Are you finding that is a smaller percentage now? Do you think that women are becoming more comfortable, particularly with procedures such as the oncoplastic?
I think, part of it is a shift in the early breast cancers are being treated with breast conservation and radiation. And so there's more women who are having breast conservation, which is good. I think that's really good. One thing I think is unfortunate is those patients having mastectomy often don't have the availability of reconstruction because a lot of plastic and reconstructive surgeons are not really interested or able to do breast reconstruction. So I think that's another area that we really have to look closely at and make sure in the future we train surgeons to do breast reconstruction and be committed to that, because there are a lot of women who really do still need that. Well,
let's go back a little bit to your recent accomplishment, getting the Lifetime Pathfinder Award from the American Society of Breast Disease. By the way, congratulations. How incredible
Thank
is
you.
that? To be recognized, it sounds like, by your peers, which is absolutely wonderful. Can you tell us a little bit about the American Society of Breast Disease and the award itself?
Sure. The American Society of Breast Disease it's been around for quite a long time. It's in its 39th year. It's an all-volunteer organization that is made up of healthcare professionals and providers of all different disciplines. So, for example, there are surgeons, radiologists, radiation oncologists, pathologists, medical oncologists, all the specialists that take care of the breast cancer patient actually form this society. And I've been working with the society for 27 years or so, just because out of interest, when you go there as a surgeon, it gives you the opportunity to actually learn about pathology and medical oncology, all the other aspects of your patient's care. And so I think in a way it's kind of magical what comes out of those meetings because it's multidisciplinary. And the society itself was pretty instrumental in teaching the multidisciplinary approach on a national level. So it's been very successful, and a lot of hospitals now have tumor boards where the specialists come together and they discuss the patient's cases. And again, they get different ideas when they interact with the specialists in other areas. So it's been a very productive society through the years, and it's been great to be a part of it. The award itself, I was kind of shocked that they had selected me because I spent many years, as I mentioned, just kind of nose to the grindstone, trying to improve surgical techniques and innovate different devices to improve patient care. And I was really very honored to receive it because, as you mentioned, it is an award that is peer-reviewed, and basically you're selected by your peers of all the different specialties. So I felt really great about it, and it was really a wonderful evening. So I was very honored to receive it.
Wow. Well, congratulations on that.
Thank you.
We need people like you. We really do. We need those that because what I see in your biography is that you think outside the box. And you really focus on the problems that are there. For example, just the mammopad, talking about that. Mammograms aren't a whole lot of fun, but it sounds like that is a way to help and gain comfort.
Yeah, the innovative part of this is really been the most gratifying thing I've ever done in my career because, for example, the mammopad, as you brought it up, it's a very simple idea, but getting that to market was, it was a really interesting and involved process with the FDA, and, there's quite a lot that you have to go through. So it's an interesting time because you may think outside the box, but you have to color inside the lines. And, to date, probably 90 million women have had the opportunity of using the mammopad. So it becomes quite significant rather than just doing surgery one-on-one, which is also fabulous, but being able to improve care for 90 million women is a whole nother, that's a whole nother dimension.
Absolutely. Well, I want to bring Dr. Fott into this conversation. Let's talk a little bit about the field of radiation oncology now and breast cancer. Tell me a little bit about your experiences, Dr. Fott.
Okay, well, I'm in community practice in Kentucky, so breast cancer does make up an important part of my practice, and it is something I think I have a particular passion and interest in. we do work closely with surgeons like Gail that I had the pleasure to speak with today that are also very interested in doing the best kind of surgery that they can do to, again, like she said, and I want to echo that, the importance of both, taking care of the cancer and reducing recurrence risk as much as possible, but also providing the best functional and cosmetic outcome as well for these patients, who many of whom nowadays, again, are early stage and are going to live long and healthy and productive lives after this. So we're trying to leave as minimal impact for these patients as possible. And I think radiation oncology is always sort of a battle between treating the area that's at highest risk to harbor cancer still, yet protecting normal tissue that has a very low likelihood of containing cancer.
Absolutely. And, let me ask both of you, as far as patients with breast cancer having follow-up radiation, is this something that is increasing? Is it something that you're seeing is on the rise?
I think it has. I think as the large and seminal studies that were done on the topic of breast conservation, which is really removal of the tumor plus some amount of normal breast tissue surrounding that, followed by radiation treatment. I think the more that has matured over time, and as Gail said, probably appropriately, giving time for that to integrate into practice over the last 2 decades or so, has generally seen increases. And I think that, again, there's a recognition that if we can maintain the body's integrity, the form and the appearance of the chest, that's generally going to be a more acceptable or preferred outcome as to one where we have to remove more tissue or have potentially more changes to someone's body image. So it has increased over time.
Any thoughts on your side about that, Dr. Lebovic?
Yeah, I would echo what Dr. Fott said. I think as the numbers increase of the women that are having breast conservation surgery, the important thing about that is to understand that lumpectomy, where we just take out the tumor and we save the breast, it's a package deal, because the majority of the time you have to have the tumor removed and then you have to have radiation to the area around where the tumor was. If you do not have the radiation, you're at a high risk for the tumor coming back in exactly that same spot. Even if, the specimen or the margins are clean and it shows no cancer remaining in the breast, over time there is still a chance it can come back. And that's what the radiation is for. So, one of the struggles that we've had through the years is how do we best find that area in the breast where the tumor was removed and the radiation needs to go. And that's a really important and difficult thing. Although it sounds easy to do, it's fairly difficult to find that area.
And obviously, finding the area and making sure that you cover everything is so important. And I have a question for that when we get back. But what we're going to do right now, Dr. Lebovic and Dr. Fott, is take a short commercial break. Don't want anybody to go away. We will be right back in just a few minutes.
Exercise your way to health, your way. with experts online who will design an effective wellness program based on physical condition and level of activity for less than the cost of an hour with a personal trainer. Use the discount code SOS1 for a 10% discount. ExerciseMD.ca. That's ExerciseMD.ca. Start getting healthier today.
Welcome back to CancerSOS, and today we talk breast cancer, and the best way to treat breast cancer really is what we're talking about. And we're talking with Dr. Gail Lebovic, who is a recent Lifetime Pathfinder Award winner from the American Society of Breast Disease, and Dr. Ryan, I'm not talking good today, Dr. Ryan Fott, who is a radiation oncologist, and thank you both again for joining me today. We were talking about finding the tumors. We were, when you look at treatment, breast cancer treatment, I've had many, many shows, obviously, on dense breast tissue, which is a huge problem with finding the cancer early. And, I hear a lot of people say, I'm going to approach this question to both of you, and then we're going to go on to some wonderful new work that you're doing, Dr. Lebovic. I hear many people say, well, I had more tumors than what they actually discovered originally. Are we getting better? I mean, because obviously the key thing is finding the cancer early, and are we making some strides in doing that? I'm going to open that up to both of you.
Well, I think that's a fascinating question. And, we have made incredible strides in the last 15 to 20 years, based upon the original huge improvement, which was screening mammography. Screening mammography basically takes a large population of women, like all of the women in this country, and yearly uses mammography to find changes in the breast at an early stage. And that became standard pretty much in the 1970s and 80s, and it made a huge difference on the survival rates of women because we were finding cancers earlier. Your question about having cancer in, more than one spot is also an important question, and ultrasound and MRI are two techniques that have now become part of the mainstream in breast cancer care to help determine exactly that. Once you find a tumor, is there anything else somewhere else in that breast, or is there something very early in the other breast? And it's important for a comprehensive approach to figure that out before you plan your surgery, because what you don't want to happen is have one cancer treated and then a few months later come back and have one in the other breast or in another area of the same breast. So I think it's a very important question, and it drives the whole theory behind having a very comprehensive workup before the treatment plan is determined by the team.
Dr. Fott, do you have anything to add to that?
No, I agree. I mean, I think we do have more tools at our disposal now than in the past, of course. I think those things have helped supplement, particularly in some difficult cases that don't always show up well on mammography. But, I mean, mammography has sort of remained the gold standard, and I think will continue to be so. So I agree with what Gail said, and I think we could certainly look at cases where, supplemental imaging with MRI and, of course, ultrasound has really helped us best define the extent of disease in the breast.
Now, do you practice, Dr. Fott, do you practice in a highly populated area or a less populated area? Do you think it's different depending on where you are?
I think it can. I mean, I practice in a health system that serves several counties, and Kentucky and southern Indiana, and we do have a good kind of community outreach in this area. We do women have high rates of mammography utilization and so forth. So I think I do see a pretty representative slice of patients that where I would see many early stage breast cancers. Certainly the majority is my practice, but despite that, we still see certain cases that patients who either don't have mammography as frequently as perhaps they should, or in some cases, of course, there's patients that don't have them at all and present with more advanced stages of disease. So I think my practice is probably fairly typical.
Okay. I had one more question on the oncoplastic surgery that I thought about, Dr. Lebovic. We were talking actually through the course of this discussion, I hear a lot of women who decide not only to have a single mastectomy, but to have a double. Do you do oncoplastic surgery on both, or do you do it at a single at a time, a single breast at a time?
Absolutely. Yeah. There is a trend, especially for women who are found to have a genetic predisposition for cancer. For example, Angelina Jolie, we all know about that famous situation. So there is that situation where bilateral mastectomies are performed even in the setting where there's no cancer. And that is the best case scenario for oncoplastic surgery because you can save all of the skin. You can sometimes even save the nipple and areolar, that whole area, so that the breast, once you've reconstructed it, looks very natural. And the sensation is not there as it is before surgery, but cosmetically the outcome is very good. And I think especially in the case where you have bilateral surgery, oncoplastic surgery is really critically important.
Wow, thank you. I thought about that and wasn't sure, so thanks for clarifying that. All right, well, let's turn to this wonderful new device called BioZorb, and it's your most recent innovation in breast cancer treatment, Dr. Lebovic. This device, if I'm understanding it correctly, marks the spot where the cancer has been removed for breast cancer patients having a lumpectomy. Why is that important?
Well, we've touched a little bit on that already. Dr. Fott, as he was explaining, the radiation that goes along with lumpectomy, as we mentioned, it's a package deal so that we can decrease the likelihood that the tumor comes back. But when you're in surgery and you're removing the lump and a little bit of extra tissue around it, there's not a good way to mark that for the radiation oncologist who is going to see that patient several weeks later. And so, for years, we religiously have tried to utilize different things like little clips and things like that, but they were not very helpful, and maybe Dr. Fott can actually comment on that. And so, together with a team of engineers, I've been fortunate enough to work on this project, which is incredibly exciting, probably one of the most exciting products I've ever brought to the community. And it basically is a bioabsorbable material, much like sutures that the body dissolves, and it's shaped in a spiral. It's an open spiral, and it has several little markers attached to it. So it defines the area where the tumor was removed. So the surgeon removes the tumor, sews this little device in place, and then weeks later, the radiation oncologist can actually see that on a CT scan. And after the radiation treatments are delivered, it dissolves by the body, and the little clips remain to show on mammography and, in the future where that tumor was removed.
Okay, so Dr. Fott, in your practice with women undergoing radiation treatment, who is a candidate for this? And let me ask you both, can this be on a cellular level? For example, last year they found some suspicious cells in my breast, and they had to put the little clip in there. Now I realize that I didn't have to go through radiation surgery, but can't, or any other kind of surgery, but can it also be used even on a cellular level?
Okay, well, where it comes in helpful for us, again, is it's sort of a direct communication from the surgeon to me, the radiation oncologist, to sort of mark the spot where the surgery was performed. And I mentioned earlier about advances in imaging the breast beyond even mammogram, MRI, ultrasound, but you didn't hear me mention CAT scans. That CAT scans are sort of notoriously not great at well-defining the breast, and it just so happens that most radiation therapy planning, modern planning, occurs on CAT scans. So to come up with a device that would sort of maintain the three-dimensional structure of, a portion of tissue that's been removed from the breast is really what we need in order to be as accurate as we can be in what we do, because there are approaches where, I say the most common approach is where we do irradiate the entire breast, but then of the portion immediately surrounding the lumpectomy usually receives a somewhat higher dose we call boost radiation, and that turns out is an important part of our treatment as well as the boost portion. So I think having this marker in there for the accuracy, allowing us to target a bit more tightly the area at highest risk, I think over time we'll see that with use of this that we're able to have better overall results, because if we're able to minimize the portion of the breast that receives the highest dose, then I think that ultimately the cosmesis of the breast is probably going to be improved as well.
So, Dr. Lebovic, tell us where I know that it appears that there have been several clinical studies already on the BioZorb. Where are we at in actually bringing this to the patient?
Well, the BioZorb is actually FDA approved, and it is now commercially available since June approximately. But many patients, well over 200 patients, have had the device implanted for over 2 years, and the results have been pretty extraordinary, which is what's so exciting about the device. It's a very simple device. I wish I could show it to you, but you could always see it on our website. But it's a very simple device that the surgeon places and sutures in place, and as Dr. Fott mentioned, it helps to maintain the shape and the contour of the breast where that tumor was taken out, so it helps to avoid getting a divot, or an indentation in that spot. But I think much more importantly is what we've seen on the radiation oncology planning side. Let's not forget that the breast is on the chest wall, and it's overlying the ribs and the lungs and the heart. And unfortunately, when the breast is irradiated, if you radiate the whole breast, the underlying structures like the heart and the lungs do get exposed to some radiation. And that can prove to be a problem. And it's part of why we've been trying to focus that beam of radiation, as Dr. Fott mentioned, more specifically to the area that needs it in the lumpectomy cavity. And that was the theory behind the device. So the device is FDA approved. We haven't had any device-related complications or anything like that. It's being very readily adopted pretty rapidly across the country. And it's just a really exciting time because I do feel it's a tool that has been needed for a long, long time.
Well, I'm actually looking at a picture of it, and it's pretty space age. It's pretty amazing. But I think that it's also very exciting because, as you said, it's important to focus the radiation to prevent future problems, in other areas. And because people don't think of radiation as having any long-term effects, but it really can. So that's pretty exciting.
I think the other important point, and maybe Dr. Fott can comment on this, as far as quality of life goes for patients, when we do breast conservation, the radiation treatments are actually once a day, every day for 6 weeks. So it goes over a long period of time, and it's very difficult, especially for women who are working or who may live out of town. Now, the technology is such that they can actually deliver the radiation in a shorter period of time if they have a better target. And we're hoping that we'll see with the use of the BioZorb that they'll be able to focus that beam and deliver the radiation in a shorter period of time, like 3 weeks versus 6 weeks, and in some cases even 5 to 7 days. Maybe Dr. Fott can comment on that.
Sure. I think shorter radiation schemes have definitely been more the trend recently, in recent years. I think particularly approach called partial breast irradiation, which some important trials have been completed, and we're still waiting on kind of the final analysis of that, but at least all of the evidence that's available suggests that certainly there's a group of patients that we can safely irradiate just the portion of the breast, and that's typically done in a very rapid fashion of 2 treatments per day for 5 days, even as one popular scheme. So I think as we adopt approaches like that, devices like this that are able to make us more accurate in our definition of the lumpectomy cavity and the delivery as well, I think the importance of it only gets greater. And I think another thing for the radiation oncologist is, as Gail mentioned, it can be difficult to define the lumpectomy area. But I'm fortunate to work with a surgeon that does routinely do oncoplastic surgery. And sometimes there's some special challenges if breast tissue has much more breast tissue has been rearranged or even removed along with a typical lumpectomy in order to provide sort of like a breast lift along with surgery, with the intention of later also symmetrizing on the opposite breast. And I think whenever that kind of amount of tissue has been removed, particularly the use of a marker like this to tell me where the area at highest risk was before, I think is again particularly useful.
And I see here, Dr. Lebovic, that BioZorb is applicable to virtually all forms of radiation therapy, which is really, really important. So because you can use it in a wide range.
Yeah, it's been reported. There have been many, I think now there's 17 scientific presentations that have been done by various users of the BioZorb, and it's across all the different methods of radiation, as you mentioned. We're really hoping that it has very broad application and just helps to improve the accuracy overall of radiation therapy for women.
Well, let's talk about that a little bit, because I think based on everything that I've heard, a lot of women opt for full mastectomies because they don't trust lumpectomies. So I think the bigger picture here would be perhaps, now you guys are the experts, I'm not, is that in the future what we would see would be more and more women going for a lumpectomy because the radiation therapy can be done more precisely and maybe not having to have the long-term effects of a full mastectomy. Am I oversimplifying?
No, I think you're absolutely right, and there are other factors that weigh into that as well. Some women choose mastectomy because they don't have radiation therapy available in their town. And, there are so many things that go into these decisions that I think the more we can standardize things for not only the surgeons but also the radiation oncologists, if we can have a device that's simple to implant into a patient and then she travels down the road, and she can have 7 days of radiation instead of 6 weeks, then it becomes a real option for her. Whereas she may not be able to be out of town for 6 weeks for radiation, so she would choose a mastectomy. So I think you're absolutely right. I think it will probably lend itself to helping to increase breast conservation rates.
And obviously long-term outcomes, I mean, because women that go through full mastectomies, and not just full mastectomies, but double mastectomies, obviously lymphedema, many different other problems. Mm-hmm. So they're very exciting. Well, what about if there are several places in the breast? Can you use more than one Biosorb?
Well, in general, women who have what we call multifocal or multicentric disease, which is disease in more than one area of the breast, they are generally not good candidates for breast conservation. So they typically would wind up having a mastectomy with a reconstruction rather than having breast conservation, but it's a good question. We do have patients who have had Biosorbs in both breasts, for example.
Oh, okay.
Yeah. As long as they're a good candidate for breast conservation, then they're a good candidate for Biosorb. And we actually are just about to start a national registry with two very prominent principal investigators. One is a surgeon, Dr. Kerry Kaufman, and he's in Bellingham, Washington, and the other is Dr. Goyal out at Robert Wood Johnson's in New Jersey. And both of them are heading up a national registry for the Biosorb. So that's very exciting as well.
That's amazing. And I see here as well that it can be used, obviously, when you have one of these spots, they have to be watched very carefully, not just on the short term, but also in the long term. And it looks like Biosorb is going to help with that.
Yeah, as you mentioned, I think before that you had a small biopsy, like a needle biopsy. And on mammography, when you go back every year, they need to be able to see where that area was so they can watch it closely. Well, the Biosorb also helps them do that, except that it defines a larger, three-dimensional area rather than just a point. But it does help the radiologist follow the patient long-term as well. So we're very excited about it.
Absolutely. And so this is obviously being received well in the breast cancer community, because that can sometimes be a pill trying to get new products through to the patient.
Of all the products that I've ever had the opportunity and the privilege of, bringing to the community, there's no question that this one has had the greatest acceptance, and it's really hard for us to keep up with the adoption by the physicians, because both the surgeons and the radiation oncologists both recognize that it's kind of a simple solution to a long-standing, challenge.
Well, it's pretty amazing, and I applaud you. I applaud both of you for your work every day on the front lines of breast cancer, but certainly, for thinking outside of the box here. And if you want to, we're running short on time. I hate to say that, but I want to thank both of you, Dr. Gail Lebovic and Dr. Ryan Fopp, for being with me today to talk about this. And if you want to learn more, it looks like your primary website is www.focal, Focal Therapeutics. Is that .com? Is that correct, Dr. Lebovic?
Actually, it's probably easier to go to Focal RX, which is FocalRx.com.
Okay, and you can certainly learn so much more about this, and I hope that this grows really quickly and is available in all areas. What about a world market? Are you also working to take this to other parts of the world?
We are, and actually we started in New Zealand, and they are right now in the process of adopting it for their public health care system. So it's pretty exciting, and we are in the process of extending it. But as I mentioned, it's kind of hard to keep up with it all.
I bet it is. I bet it is. And keep up your good work, and I'm looking forward to seeing what new products you have coming out next.
Thank you.
Keep thinking outside the box. We need doctors like you, and you as well, Dr. Ryan Fott. Thank you so much for joining us today as well. This is Joni Aldrich, JoniAldrich.com. I want to thank you for joining us today. Remind you that we're on every day at 2 p.m. Eastern Time. Tomorrow will be Advocacy Heals You. And also to remind you that past interviews are on iHeart Talk Radio. Have a great evening.